Thank you for this question. As you know, leukemia is a very tough disease to cure, especially for older patients. The survival long-term is still less than 20%. So we clearly need better treatments and novel regimens. So I think I'm motivated to find out novel, more effective treatments so that the majority of the patients who are actually median age is 65 years old, they can enjoy long-term survival. Also, the quality of life is very important in older patients because they cannot withstand high-dose chemotherapy and stem cell transplant. So we are aiming at finding low-intensity regimens that they can tolerate without having spent too much time in the hospital, without too much transfusions, without clinic visits as much as possible. Still, these treatments have to be effective. So this is very challenging because leukemia, at least acute myeloid leukemia, has multiple clones. And so if you get rid of one clone, then the other will sort of arise. And needs perhaps different treatments. But altogether, I think we made great progress. And we have now new regimens, which of course we'll talk about later. And I feel very encouraged by that. So I continue my work on preclinical and clinical trials in leukemia. So the review that we published was on the Venetoclax, which is BCL2 inhibitor that was largely developed at MD Anderson, and the initial preclinical studies were done in my laboratory and in collaboration with the scientists at Dana-Farber, Dr. Anthony Letai. But despite the fact that this is a highly effective agent, on its own, it has limited activity, again, because leukemia can escape very easily. So since the original discovery, we moved into multiple combination treatments, which include both chemotherapy combinations, hypomethylating agent combinations, targeted therapies, and immune therapies. So we'll continue to improve these combination regimens, trying to extend the duration of response to venetoclax-based therapies. And this approach has yielded a lot of promising results. For example, in younger patients at MD Anderson, we have developed a regimen called FLAG-IDA Venetoclax, which has been recently published. So this allows the response rates above 90% in younger patients, and a lot of them are able to proceed to stem cell transplantation. So we actually think that we can increase the cure rates of younger patients to perhaps 60–70%. In older patients who are still able to tolerate chemotherapy, we also have developed low-intensity chemotherapy with alternating different drugs, such as cladribine, low-dose cytarabine, azacitidine, and venetoclax. And again, the study was recently published by Dr. Kadia and has shown really durable responses, high response rate, very low mortality, and low side effect profile. So this is on the kind of clinical basis where we made a lot of progress in combination with chemotherapy. But in the laboratory, we also are developing other agents that target the cell death pathway, such as looking at BCL-XL and perhaps MCL1 inhibitors as well. There are subsets of leukemias that depend on this other alternative BCL2 family members. And in addition, we're also working on the novel combinations with venetoclax, such as targeted therapies and immune therapies. And some of this has already transitioned into clinical trials. These are early stage clinical trials, so we need some time to see how really they will work in our patients. But I think I'm hoping we're on the right track, and we made a lot of progress already, but we need to continue working on that topic. Yeah, so I think it kind of goes back to original discussion, but essentially venetoclax is an inhibitor of BCL2. So BCL2 is really important for survival of AML cells. So if you use this drug, you will lower cell, apoptosis threshold. So the cells will be easier killed by anything. So it's chemotherapy, targeted therapy, anything you name it. So we call it like universal sensitizer, right? But still the resistance can arise. And usually what we found that if patients progress after initially being in remission with Venetoclax regimens, the survival is very poor. So we cannot, at the time of progression, something happens, so we are unable to rescue them so far with the regimens that we have tried. So published that the survival of all the patients who progress is only about 3 months. So we decided that this is obviously, really bad, and that we need to perhaps use upfront the combination therapies that will extend this duration of response and get rid of these residual cells upfront, not when they dominate and when they develop, they have multiple changes. At that point, it's really challenging to reverse the resistance. So that's why the approach we're taking is to identify rational combinations of Venetoclax with, for the most part, backbone of low-intensity chemotherapies, but such as azacitidine or decitabine, but adding to that, because this is FDA approved, but adding to that novel regimens. So examples could be, we found that AML patients who have mutations in FLT3, which is fairly common, they do respond to this regimen, but then they relapse earlier because this clone can develop dependence on other BCL2 family members, such as MCL1. Since MCL1 inhibitors are not yet available in a clinical setting, we took an approach of combining FLT3 inhibitors with Venetoclax and low-intensity therapies. And that turned out to be quite effective. So again, from the very beginning, we targeting the mutant clone with the FLT3 inhibitor, and then we're using Venetoclax that helps to lower the threshold and help this inhibitor to work. So that has been taken now into clinical trials. Several of these are ongoing, and treatment results are very encouraging. So this will hopefully be one day an approved therapy for patients with this FLT3 mutations. But this is basically the reason why we continue this research, because we found that while therapy is very effective, the hypomethylating agent Venetoclax patients, all the patients treated with this regimen, the median survival is only about 15 months. So, and then most of them would progress, except for a few patients who have what we call very sensitive mutations, such as NPM1 or IDH1 or 2. So the majority of patients will progress, and then at that time, it's really hard to rescue them, and especially because they cannot, tolerate chemotherapy, so the options are pretty limited. So that's the reason that we are trying to use combinations, either several agents together or sequentially. So this approach is still being discussed, and we don't know what is the best way of doing that, because the issue when you combine multiple agents, you run into some toxicity issues. Most notably is myelosuppression, because Venetoclax can affect normal myeloid progenitors and cause neutropenias, and that, in conjunction with anything else, would make patients more susceptible to infections, sepsis, pneumonias, and death, essentially. So that's the reason, that's a challenge, to find out the combination that is effective, safe, and figure out what is the best schedule. With the ultimate long-term goal is really to extend the duration of response and survival of the patients. I actually don't like the terminology shotgun, but I would say the combination approaches. So there are two ways of combining regimens with Venetoclax. One is to do what we call now in the field triplet combinations. So let's say we have a backbone that is FDA approved, which is azacitidine and Venetoclax, and then we can add the third drug to that. So again, the third drug and the example that I gave you before is a FLT3 inhibitor, right? So this is like one way of doing things. And there are multiple combinations now that are being done in that fashion with different, for the most part, targeted agents or immune agents. From the immune agents, for example, one of the reported ones is anti-CD123 monoclonal antibody from Immunogen, IMGN 263. So that targets CD123 on AML blasts and helps chemotherapy to get rid of the leukemia cells, including leukemia stem cells. So these approaches are generally very effective in inducing marrow clearance and remissions. But the issue is, again, that if you do more and more combinations at once, patients develop prolonged myelosuppression and delayed count recovery with infection complications. So because of that, we have to modify this regimen, and the way we modify that usually is we reduce duration of Venetoclax from the approved 28-day schedule down to, let's say, 21 or even 14-day schedule. Now, these reduced durations are not FDA approved, so it is a bit challenging to do it that way. But what we found is that even with this 2 or 3 week duration, if we combine with a new agent, we usually get bone marrow remission at that time. So we basically, the way we design the trial is that we use the triple combination and then do bone marrow around day 21. And if bone marrow has no blast, we hold the therapy to allow for count recovery. And so this approach, again, has been quite successful, but obviously you need to be very carefully manage the cytopenias, infection complications, stop the therapy appropriately, allow for count recovery, and reduce therapy in the subsequent cycles. So that's one approach. So the other approach that has not have as much precedence yet is sequential approach, where you do, let's say, 2 drug combinations followed by 2 drug combinations. So the only example that I'm aware of clinically is the trial which was presented by Dr. Andrew Way from Australia, where he combined low-dose cytarabine with Venetoclax, followed by Venetoclax and midostaurin. So midostaurin is a multi-kinase inhibitor that also inhibits FLT3 mutation. And using this approach, he was able to get very good responses, and also it prevented the myelosuppression. So the count recovery was within the expected range. So I think we will see more and more of this sequential approach, and with the time, we'll find out which approach, or perhaps both of them, will be clinically more viable and more accepted by the community and eventually lead to the FDA approval. Yeah, so these are what I guess in the article we call the shotgun approach. I would rather say that this is combination approach. And the field is collectively trying to figure out what is the best way of doing the combinations, because to avoid the side effects. In AML is certainly emerging. So there's several flavors of immune therapy. So the one I already mentioned is antibody drug conjugates. When the immune therapy is antibody that targets cell surface protein highly expressed in AML, for example, such as CD123. And then the antibody is conjugated to the toxin that induces cell kill in cell type specific fashion. So again, I already mentioned this trial that is ongoing with azacitidine, Venetoclax, and IMGN 263. So, and it's in the relapse refractory setting, and the results look fairly encouraging. And the goal is to move it to the frontline setting. Again, because also leukemia stem cells express CD123, so the idea is to target leukemia stem cells and extend the duration of response. So the other immunotherapy that has been really kind of taking off recently is the drug called magrolimab, which is anti-CD47 antibody that was initially developed by Prof. Weissman from Stanford. There are multiple other antibodies that also target CD47. So this is the one that is most advanced by the company Gilead. So essentially what it does, it blocks CD47 that is expressed on tumor cells, on leukemia cells, and it is what we call don't eat me signal. So it prevents the macrophages to phagocytose AML cells. And it's expressed in many different many different tumor types. So it's been tried in other malignancies as well, but I will only talk about AML. So initially, the trials have shown that the combination of magrolimab and azacitidine is quite effective, in particular in a subset of patients who have p53 mutation. So the p53 mutation is, I would say, the most unmet need in AML because the responses to even venetoclax-based therapies are short-lived, and they are not good quality responses. Most patients have residual disease, and majority of the patients progress. So venetoclax failed to improve the outcomes of the subset of patients, and there's a biology behind that because p53 controls cell death. But the magrolimab has been shown to be effective regardless of p53 because phagocytosis signal does not really care about p53 mutation that much. So that has been really like promising, and what we have done is we have performed preclinical studies and then moved it into clinical trial where we combined the azacitidine, venetoclax, and magrolimab in both patients with p53 mutation and without p53 mutation. So what we showed in the lab is that venetoclax is actually able to by itself induce some phagocytosis by macrophages, and when you combine with magrolimab, the effect is more prevalent, higher. So these trials are again ongoing. They have been presented at ASH and EHA and will be updated this year again. And this is one example of this triplet combination where we, in the same cycle, combine azacitidine with venetoclax and magrolimab. And that will be moving into larger phase studies very soon. So other forms of immunotherapy in AML have not yet been combined with venetoclax because they're still in early stages of development, such as bispecific antibodies, CAR T cells, and the NK cell therapies. So each of those approaches, while highly promising, had its own side effects and limitations, and none of them are yet FDA approved. So there has been no study that would combine venetoclax with some of these agents. However, there was a preclinical study published recently in the journal Cell by Tony Letai's group that showed that venetoclax plus NK cells is actually highly effective. So I think in the future, I'm sure we will see the combinations of venetoclax with the cellular therapy as well, but that has not been yet the case. So a lot of excitement. I think the hotspots, like unmet need, right? Or yeah, so or like most promising things. I think the most promising approaches from what it's my personal opinion are the approaches of targeting CD47 that I just described in combinations with other therapies and cellular therapies. The CAR T cells so far has been not as effective as an ALL because there's a shared antigens between leukemia and normal cells. So there's a lot of toxicity and limited efficacy, but the new CAR T are being exploited. The NK cells have been recently moved into clinical trials, and they seem to be less side effect prone and perhaps more effective. Again, the studies are still very early, but I think a lot of scientists or clinical investigators Yeah, so it's different for younger and older patients. I think for younger patients, probably the chemotherapy will stay as a backbone for foreseeable future. I fully believe that adding venetoclax to chemotherapy will take place very soon, and there are a lot of trials ongoing to show that. And then most of these patients will still proceed towards allogeneic stem cell transplantation. And then depending on the risk, the maintenance approaches after the stem cell transplant will be utilized. And again, the studies are ongoing, and this will be personalized based on the type of leukemia, genetics, molecular aberrations of leukemia, so that for each patient, we hopefully will have a specific intervention that will allow them to get to the cure. For all the patients, again, these are majority of acute leukemia patients, myeloid leukemia patients, and they are certainly more challenging. So the goal is to come up with the therapies that are less toxic and more effective. And that's where I see this triple combinations or sequential combinations will grow more and more and perhaps again take place. And I think there will be also personalized depending on the genetics. For example, for FLT3 mutated, we will have the FLT3 inhibitor combo. For the IDH mutated, we can combine with IDH inhibitors. For P53, perhaps with magrolimab. And these patients may or may not be able to undergo stem cell transplantation. So we have to rely on these low intensity therapies long-term to maintain them in remission. So I think that's where the field is going. And then obviously, using some of these novel immune therapies that I already mentioned to eradicate minimal residual disease, that will be the goal of the future.